We'll be talking on shoulder complex dimension, and this is going to this is going to involve. Oh, just 1 minute, please. Clavicular joint, acromioclavicular joint, glenohumeral joint, and scapulothoracic joint. So we are going to be discussing all this, right, as we are moving on gradually. So these are the 4 joints we are going to be discussing today. Talk about the anatomy, talk about the nervous involvement, talk about some of the pathophysiology of each of the joints. Right. So we start from glenohumeral joint. Right. When we talk about glenohumeral joint, we are talking about shoulder joint specifically. And when we talk about the shoulder joint, right, we talk about the articulation, the head of the humerus, the glenoid fossa, right, and the articulation there. We talk about it. It is made up of ball and socket type of joint. A synovial joint in the human body, and most of the unstable and free joints in the human body. Right. The shoulder joint is formed by an place between the head of humerus, yes, and the glenoid cavity of the scapula. Right. This now translates into the name shoulder joint or glenohumeral joint. They are the most common synovial joint. The articulation surfaces are with hyaline cartilage, and you can see the cartilage that we put in blue color here. This is the hyaline cartilage, which is the colored here, right? The head of the humerus, big, the glenoid fossa, small. The two of them comes together to form glenohumeral joint. Unlike the hip joint, in which where we have the head of the femur that's a bit big, that can enter into the acetabulum, the space of the glenoid fossa here is not large enough, or concave enough, or hollowed enough to accept the head of humerus here. Therefore, the head is easier, and they cannot enter there. That's what makes the joint to be a bit relatively unstable, at least of the joint, right? So we have fibrocartilage that surround the joint that make the joint to be a bit good enough to do some functioning. There we have what we call joint capsule. And I try to put the picture of the capsule here. The capsule is like a cloth or a kind of bag that wraps the head of the humerus and joins to the edge of the fossa, right, and try to capture the joint together. It's a fiber sheet which encloses the head of the joint. It extends from anatomical neck of humerus, right, to the rim of the glenoid fossa. Joint capsule is large, that is not too tight. Therefore, it permits mobility of the joint. It makes the joint to be a bit movable, right, in all range that are available in the joint. Inside the capsule, as you are looking at it, inside the capsule here, you can see my console. Inside the capsule, we have the synovial membrane. The synovial membrane lines the surface of the capsule. Do you understand? And inside it, we have the synovial fluid, which reduces the friction between the articular surfaces of the joint. And it is that synovial fluid that really nourishes the joint. That doesn't make the joint, right, to go into early osteoarthritis. So if the synovial fluid is decreased in length, in size, right, then in addition to that, we have the ligament of the joint. And this ligament, they do a great job in the sense that you know that the joint is not stable. It's not stable in the sense that the articulation is not as strong as compared to other parts of the other joint, like the hip joint. No, the joint is not as stable as that. So those ligaments they are doing a lot of work in making the joint to be compact, right, and make it to be available for the work it's supposed to do all And this the glenohumeral ligament, you can see my cursor moving. Yes, the glenohumeral ligament here is large in size. It's large in size. It's large in size. And here we have the superior. We have the superior. This is the blue color you are looking at up here. We have the inferior. This is the one that we are looking at. And we have the anterior. So they come together to form what we call glenohumeral ligament. And that coracohumeral ligament here as well. And all those ones, they are assisting the capsule, or they mark the capsule. They support the capsule of the shoulder joint to make the strong good enough for the work that has been made to do. Along that line as well, we have what we call coracoacromial ligament. And this coracoacromial ligament comes from the acromial process and go into the coracoid of the bones of the scapula. And that's why it forms what's called an arch. This is the arch that you are seeing. And this arch serves as a cushion that doesn't allow the head of the humerus to dislocate superiorly or posteriorly. It serves as some kind of ceiling that is sealing the thing back. So we call it coracoacromial ligament. So those are some of the strong ligaments that we have in the shoulder. But apart from that, we have some other ligaments that were not specifically for the glenohumeral joint. We will get there as we are going on. Right. Then follow that, we have the bursa. There are many bursa in the shoulder joint, and that bursa, they are serving purposes. Right. One of the purposes is that they were just like foam that God has placed under some group of muscles to produce additional cushioning effect when muscle is moving. Doesn't allow the muscle to rub on each other. The prominent one among them is subacromial bursa. Subacromial bursa is that we have subdeltoid bursa as well. Subdeltoid bursa, that under the middle fiber of the deltoid, we have subacromial bursa as well. Right. Then we have there's another one. Then we have coracoid bone. All right. So all those ones were bursa that we have. Then we have subscapularis bursa here. This one is hiding possibly in the armpit, and it's preventing a lot of movement, supporting a lot of movement that is there. So I put some literature here. Those bursa, they reduce friction, but say on the tendon, minor bursa present between the muscles around one that of value, at least for this presentation. We are familiar with the movement. It's something like it's extremely mobile. A joint with a wide range of movement possible. Extension, flexion, abduction, circumduction, medial rotation, lateral rotation, and what have you are present in shoulder joint. Don't forget I mentioned that the shoulder is unstable. So by virtue of that head of the humerus that was not really deep in the glenoid cavity, so it allows a lot of movement to occur at the shoulder joint. If not the most mobile joint in the body, right? At least the most mobile joint, apart from the hip joint. So for the extension, we have posterior deltoid as the muscle that are working there, proximal dorsal and teres major. For flexion, we have pectoralis major, anterior deltoid, and coracobrachialis. Bicep brachii weakly assist in forward flexion. For abduction, right? For the first 10 degrees of abduction is produced by supraspinatus. The middle fibers of the deltoid are responsible for the next 50 to 90 degrees. Right? After 90 degrees, scapula needs to rotate to achieve abduction. And this carried out by trapezius and serratus anterior. So other movements include abduction, that is when the limb is moving to the midline, called the coronal plane or frontal plane, pectoralis major, that's small dorsal, teres major are major muscles responsible for this. We have internal rotation, which is responsible to subscapularis, pectoralis major, the small dorsal, teres major, and anterior deltoid, right, of muscle. Then the internal rotation, infraspinatus and teres minor. Then circumduction, which produced by the combination of movement described above. All the movements above, they come together to form what we call circumduction. And most of the muscles that we have mentioned, they are responsible for circumduction of the shoulder joint. Right. Then talk about movement, then talk about mobility, we talk about stability. And stability is extremely important in the sense that if the joint is not stable, it may not be easy for the joint and rigorous work. But the shoulder joint has some mobility, it has some stability as well, which are anchored by the muscles. We get there as we are going on. The shoulder joint is one of the most mobile in the body. I've mentioned it. At the expense of stability. The what brings the stability are the muscles and the ligaments. We shall consider the factors that permit movement and those that contribute towards the joint structure. Yes. Part of joint, ball and socket, bony surfaces shallow and large humeral head. It's about 1:1 to 4 disproportion in surfaces. Right? The common use analogy in the golf ball and tee. So when you put the golf ball there, you discover a golf ball is only sitting, it doesn't enter. Then we have the joint capsule, which is lax. So joint capsule is not too tight. You understand? It is lax that can accept movement inside the joint. So those are some of the factors that are responsible for the mobility of the joint. Right? I put down here the rotator cuff muscles. I think there's another one here, rotator cuff muscles, yes. Rotator cuff muscles, which we are familiar with. Right? We have the supraspinatus, which is up there. We have the spine of the scapula, right, which is up here. We have the infraspinatus, which is at the larger surface of the scapula, posteriorly. We have the teres. I think you are hearing me.
Yes, sir, we can hear you.
Thank you very much. We have the teres minor, and teres minor is just very close to the inferior border of the scapula, very small in the muscle here. Then subscapularis is inside at the anterior side. I have another one that shows the subscapularis here. This is another one that displays more or less the rotator cuff muscle. Supraspinatus, we have seen it. Teres minor, we have seen it. Infraspinatus, we have seen it. Then we have the subscapularis. Right? Then we have the head of biceps, long head of biceps. That's what we are seeing here. Long head is not part of the rotator cuff muscle, right? But it is serving a purpose. It's serving a purpose. There are 4 of them. Supraspinatus, you call it SITS. S-I-T-S. I think I have the appellation here. Yeah, S-I-T-S. Sorry, S-I-T-S. SITS. SITS. That means supraspinatus, that's responsible for abduction. Infraspinatus, responsible for external rotation. Teres minor, responsible for external rotation as well. Then subscapularis, then that is internal rotation. All those ones were what we have at least here. So we did, in addition to rotator cuff muscle, we have the glenoid labrum. Then this is a fibrocartilaginous ridge surrounding the glenoid cavity. It produces like a cushion, at least inside the glenoid cavity, in which the head of humerus is resting, so to say, like a pillow in which the head of humerus is resting. And therefore, it reduces the risk of dislocation. Then we have ligament as well, right? Ligament that act on the joint. One of the major ones is what called coracoacromial ligament. I've told you earlier, it forms a kind of arch, and that arch is preventing the humeral head to go up. It serves as a kind of bridge, as a kind of concrete that doesn't allow the head of humerus to go up when there's a movement from the distal part of the humerus. Then we have biceps tendon. Yes, I mentioned biceps tendon on the other hand. It acts as a minor humeral head depressor, thereby contributing to the stability. So stability is brought about by ligamentous labrum, number one, rotator cuff muscle, number two, ligament, number three, biceps head. Biceps head and where it inserts that try to create a kind of pull down. It is pulling the head of humerus down so that at least it doesn't have all the effort to move on. So the arch, the biceps tendon, they are responsible for supporting the head of humerus down, keeping it in the place where it's supposed to be. If not, once you raise up your shoulder, the thing will dislocate superiorly. But by virtue of those muscles, I tell you the truth, you are able, the joint is able to be stable and can carry out our axillary nerve and suprascapular nerve. There will be others to that, but these are the major nerves that we have at the shoulder joint complex. We are talking of glenohumeral joints now. Yes, there can be some dysfunctions. I always state these dysfunctions here. We are going to discuss on them as we are moving on. Most of them are instability, arthritis, fracture. Then other shoulder and nerve related problems. We are going to discuss more on this as we are going on. Yeah. Yeah. So we can now talk of bursitis. Bursitis. Right. I think by next week, all things being equal, we are going to go to examination and differential diagnosis, because it's important for somebody to be able to know what is the problem of the patient. Is it bursitis? Is it tendinitis? Is it frozen shoulder? Is it osteoarthritis? What is it? If you don't know what the problem of the patient is, forget it. You can't get any result. You can't get any result. And once you cannot get any result, forget it. All your treatment are going to be vain. You are going to appear to patient as if you don't know it or you don't know what you are doing. Very, very important, able to get what the patient is suffering from. Sometimes excessive use of the shoulder leads to inflammation and swelling of bursa between the rotator cuff and part of the shoulder blade, acromion, so to say. You call it bursitis. Bursitis often occur in association with rotator cuff tendinitis. So what you are saying, if there is tendinitis, there is tendency for bursitis to follow. They go together, 5 and 6. It doesn't say that once somebody is having tendinitis, and inflammation can affect many daily activities, which we know. Patient will not be able to move the hand or the shoulder as supposed to do it. Common activities patient will not be able to do. Pumping the air, getting the dress off, getting the dress on, tying the wrapper, your head, brushing your teeth will be difficult because that involves the movement of the shoulder. So that involves the movement of the shoulder. And that's why there may be a problem as somebody is going on when you have bursitis. Right. Then tendinitis. Tendinitis can be active, it can be chronic, excessive blood flowing, or other overhead activities during work or sport can lead to acute tendinitis. That's sudden injury. Then there can be chronic. Degenerative diseases like arthritis or repetitive wear and tear due to age can lead to chronic tendinitis. That is, as somebody is growing older, wear and tear, repetitive usage can lead to chronic tendinitis. The most common affected tendons in the shoulder are the 4 rotator cuff muscles, right, and the 2 biceps tendon. And you can now understand why we call pushing shoulder. Because patient is unable to do the movement. So the shoulder are glued together. Patient is unable to move it. Oh, this shoulder is not movable. Call it pushing shoulder because of the pain, majorly inflammation of the tendons or tendons. Right. Then there can be tendon tears. Maybe this is resulting from possibly injury, active injury, what we call tendon tear. Degenerative changes in the tendon as well may be due to age, maybe long-term overuse or wear and tear. These tears may, one, be partial, right, or complete. When we talk of partial, maybe the tendon is only torn. In fact, they may have complete tendon, which means that means they are separated apart, right? Vertical cuff and bicep tendon injuries are among those most commonly affected. So that's why most of the time we talk about rotator cuff muscles, rotator cuff muscles, rotator cuff muscles, rotator cuff muscles, because of what they do, right, in the annals or activities of shoulder joint. So then there can be impingement. We call it impingement. I try to put a structure here, a picture here, or when you talk about the spine, there can be orthopedic goods, like boning spot. Right? The calcaneus as well, there can be boning spot, right? That can result into possibly pain at the leg. People may say it's plantar fasciitis, but when you take the X-ray, you discover that a boning spot there. Right? Likewise, when you talk about there can be a boning spot there. So that's what you are seeing there. Minor boning spot can be there. Right? So when you have minor boning spot there, no matter what the structure you have at the shoulder joint, when a patient move the joint out in abduction, then once it touches the boning spot, there is the pain. And that's what called impingement. In addition to that, there can be calcification. There can be calcification in that area. That if there's calcification maybe of ligament or what have you there, or the bone chip that deposit there, then whenever somebody moves the joint into abduction, there will be pain. So in that part, we say there's maybe impeachment, and that impeachment, that pain will be sharp. There's a way to test this. We get there when we come next week. So that thing now called when the top of the shoulder blade acromion put some pressure on the underlying soft tissues. Yes, when the arm is lifted away from the body, the arm is lifted, the acromion rubs or impinge on the rotator cuff tendons and bursa. And this can lead to bursitis, can lead to tendinitis, causing pain and limiting the movement. Yes. So irritation of that bone on those structures will make them to respond. Oh, tendinitis may occur, bursitis may occur, and that may go a long way in making the patient to be uncomfortable. But you come to instability of right. The shoulder instability occur when the upper arm, right, of the bone is forced out of the shoulder socket. I put that for us that we have the anterior instability, we have the posterior instability. We can have inferior instability as well. We can have inferior instability. This picture does not capture inferior instability. We can have it. Right. Maybe by next week when I'm talking about my examination, you understand better what I'm saying. You call it sulcus. That shows that the head of the humerus has gone down a bit, right below the normal. That's gone down. You call it sulcus. Like you said, we call it sulcus test for the shoulder joint. You enjoy it when we are moving tomorrow. So next week. This occurs when, as I mentioned, this usually happens initially as a result of sudden injury, but it can become chronic. Right? When the ligaments are weak, when there is a sudden force, it can be weak. Right? I will call it instability of the joint anterior. Once the ligament, tendons, and muscle around the shoulder becomes loose or torn, dislocation can occur. And if care is not taken, it will turn into what we call recurrent dislocation. Most of the time, anteriorly. Whenever somebody wants to wear his clothes and he doesn't know how to do it, the shoulder will just come out. And when it comes out, the activity will stop and pain will resume. And patient will be shouting. It now takes somebody that is skilled enough to be able to restore the head back into the normal position, or else patient is in trouble. So we call it dislocation, which may be partial or complete. You can see the picture I put there. It can just happen. It can happen that it's going to be complete. We call it complete dislocation. Right. Yeah, there can be arthritis. I think all of us we are familiar with this. When the edge of the articular surfaces are getting degenerated, right? It may result into arthritis. Arthritis may be related to sport or work injury or chronic wear and tear. Other type of arthritis can be related to cuff tears, infection, or inflammation of the joint lining. All those ones were kind of arthritis that you can have. Can be gout, can be what we call it rheumatoid. The rheumatoid arthritis is not really common in the shoulder joint. It can occur. That's not it. Then you can have fracture. Fracture can occur, maybe resulting from road traffic accident, from fall, or from anything. Gunshot can result into it. In this case, you have the total shattering of the edge. Total shattering of the edge of the neck of the femur. So in young patients, shoulder fracture are often caused by a high energy injury. Somebody falling from the height and land on the shoulder joint can result into breaking. Maybe somebody is playing a football and has kind of tackling that is very heavy and the man fall down, it can result into injury. Crashing into the board in hockey can result into the air. Road traffic accident can cause it. There can be pathological injury, but that may not be common. So those are some of the causes of fracture that we may have at the shoulder joint. But I try to come out with common injuries as well. Dislocation, clinical dislocation, clinically, dislocation of the shoulder are described by where the femoral head lies in relation to the glenoid fossa. Right? When the edge of humerus is no more, and the glenoid fossa, we have dislocation. Anterior dislocation carries 95%. Right? Posterior carries 4. Inferior carries 1. Superior displacement of the mirror is generally prevented, as mentioned, by coracoacromial arch. Don't forget, I showed you the other time that ligament from coracoid and acromia that come together become a kind of bar. Two of the one head of bicep that's inserted into the head, right, into the glenoid. Then it doesn't allow the head of checking the head of the humerus to go into superior displacement or dislocation. Right. Yes. An anterior dislocation is usually caused by excessive extension. Right. Yes. I think you can see this one very well for me. Yes. Please be able to see this.
Yes, sir.
Yes. Good. Yes. So I'm trying to move something here down so you can see it very well. Okay. So there's something here. There's something here. We call it ILSAC. Call it ILSAC. Call it ILSAC. There's a picture here that I want you to see very well. Right? You call it ILSAC. Yes, ILSAC. Good. Please. Call it ILSAC. Yes. It's up. Oh, sorry. Appearing now. Call it heel sac. Yes, call it heel sac. Yes, call it heel sac. So an anterior displacement is usually caused by excessive extension and lateral rotation of the humerus. Right? That's extension and lateral rotation. It can cause what we call anterior dislocation. Look at it. The humeral head is forced anteriorly and inferiorly into the weakest part of the joint capsule. So the joint capsule I showed you the other time, the inferior part of it is weak. It's not as strong as the upper part. So therefore, if accidentally the head of humerus have an opportunity of coming down to that weaker type, it will dislocate. Dislocation will not just come like that. It's going to do some breakage because the labrum there will break. This area will break. Then there can be abortion of the inferior gland. This is what we are lacking here. So if you have that, we have what we call bankard. Call it bankard. You understand? Then there can be a kind of injury here. You call that one heel sac. Call it heel sac lesion. Heel sac lesion. That's impaction of fracture of posterior head of humerus against anterior gland and bankard lesion to the detachment of anterior labrum. Sorry, let me close my door, please. What is the problem now? Oh, the nurse is not disturbing us. Is it?
No,
No,
sir.
sir.
Okay. So we call it bankard lesions. So this is what we are seeing here. Detachment of anterior inferior labrum with or without abortion. If there is breakage of the bone, that's what we call abortion. If there's no breakage, that's without abortion. So that bone may break. That's going to allow the anterior dislocation. At times, the bone may not break. So we say without abortion. So that can lead to anterior dislocation. There can be reverse. There can be reverse heel sac lesion, the fracture or the impaction we have at the end of the femur that can reverse of it. In that case, we have reverse bankard lesion. The detachment of posterior inferior labrum can be seen in the posterior lesions dislocations as well. So in that case, we have posterior dislocation. So we have anterior dislocation, we have posterior dislocation. Those are the major ones that are very important. But anterior is more common. I showed you the other time, about 95%. Whereas posterior is about 4 or thereabouts percent or 2%. The axillary nerve runs close to the shoulder joint and allows the surgical neck of the humerus. And so it can be damaged in the dislocation or with attempted reduction. Yes, if there's a dislocation, anterior nerve can be damaged. And when it is damaged, then you know the subsequently what can happen. Injury to the axillary nerve cause paralysis of deltoid and loss of sensation to the place. Right? We have here the rotator cuff muscles are tendinitis. There can be inflammation of rotator cuff muscles. So in that way, inflammation will occur, right? And this one may result from overuse. It may cause degeneration as well as in the subacromial bursa. Superclavius may be affected and there can be bursitis. All those ones were what we thought to be shoulder, pushing shoulder, and we lead to pain and what have you. Right? The characteristic sign of supertendinitis is the painful arc, which I think all of us are familiar with. That's when there's abduction, it's painful at 60 to 120 degrees. Right. Yeah. So we want to go to acromioclavicular joint now. We have discussed glenohumeral joint, acromioclavicular joint. This one forms right between the acromion and the clavicle. We call it acromioclavicular joint. And what is that is what you are seeing now. This is what you are seeing now. This is what you are seeing now. This is what you are seeing. This is what you are seeing. So I put here all the articulations here. As far as we are aligned with fibrocartilage as opposed to hyaline cartilage. The other time we have hyaline cartilage, here we have fibrocartilage. Joint cavity is partially divided by an articular disc. Yeah, that's a wet fibrocartilage suspended from the upper part of the capsule. Then we have joint capsule as well, right? In this small joint, right, we have joint capsule. You can see the beautiful work of God. It consists of a layer of fibrous tissues which is lined internally by synovial membrane. The posterior aspect of the joint capsule is reinforced by fibers from the trapezius muscle, and that's what made the strong to be stronger. I put here the structures of the acromial ligament, acromioclavicular joint, and you can see that majorly there we have three, okay, let me say four ligaments specifically. This one is what we call, right, acromial ligament, very important, right? Acromioclavicular ligament, very important. Here we have conal ligament together to form what we call coracoclavicular ligament. These ligaments are very important. You see the importance as we are going into the teaching. Please let's go on, right? To save our time. We have the innervation here, supraspinatus, another perspective, that acromioclavicular. Yes. Yes. I put something here. Yes. The acromioclavicular joints can be dislocated. And this is what we know as separated shoulder. What is this one? They call it separated shoulder. Right? What happens is that the shoulder will be separated from the other part of the neck. And that's very important. That's very serious. It most commonly occur from a direct blow to the joint or a fall on the arm. So when somebody lands on the arm, that's when they rupture, the shoulder gets scattered. So that's what we call shoulder joint complex. So you cannot just take shoulder and say, oh, no, that was very important. It's the one that links the shoulder to the other part of the body superiorly. If the clavicular ligament is torn, the weight of the upper limb is not suspended any longer, supported, and the shoulder will drop inferiorly. So the management of acromioclavicular joint dislocation depends on injury severity and impact on quality of life. Most of the time, it may need surgery. It needs surgery. Yeah. Can you see this? Yes. Can you see this? I think you can see this.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. You can see it.
So, this one is talking about this. This one is talking about the problem that we have, that complication of acromioclavicular joint injury. This is type 1, this is type 2, this is type 3, this is type 4, this is type 5, this is type 6. What does this mean? What does type 1 mean? What does type 2 mean? What does type 3 mean? What does they mean? And what's the implication of all this? We go over. Right. Yeah. Type is what's called grade as well. Grade 1 and 2, the AC joint will be stable because only few ligaments to the joint will still be stable. Joint capsule has been injured, but the important coracoacromial ligament will still be intact. So the joint is not separated. 90% will recover without surgery. 10% will develop ongoing pain. Grade 3, one will have a step over of the shoulder. On X-ray, the collarbone clavicle will have moved out of its socket by approximately 100%. That's grade 3. The coracoclavicular ligament has been injured, but it's probably that the deltoid remains intact, so the joint is not totally separated. Repeated studies suggest that most, that is 85% of patients, do well without surgery. They can still recover. And if you confirm no obvious superiority or early fixation for this injury, if the patient are not to have an operation, so there can be recovery within 10 days. If the patient is struggling at this point, then one may decide to go for surgery. Consider where the collarbone is unstable posteriorly, those behind the acromioclavicular joint, right? As the patient moves the arm close to the body, the patient are normally very sore, right? And limited by this and must well up for early surgery. If not, the shoulder will be down and patient will be suffering from pain. In the grade 5, in this case, the overlying deltotrapezial ligament and fascia has also ruptured and the collarbone has displaced, yet further from its original position, the shoulder is displaced, going down. Most surgeon will offer early surgery to restore stability in this group. Then grade 6 is an extreme case, right? It's a rare injury. The collarbone comes right beneath the coracoid process. That one may require surgery plus. I try to put the treatment there. This can be very painful injury, and the treatment is to decrease pain. This is best accomplished by immobilizing the arm in a sling, placing an ice pack on the shoulder for 20 to 30 minutes, as often as every 2 hours, and using pain medication. The pain is usually proportional to the severity of separation. As the pain starts to subside, it's important to begin moving. So that's us. Moving the finger, moving the wrist, moving the elbow to prevent stiffness. Next, it's important to begin shoulder motion to prevent stiffness or pushing shoulder. So these are something that you do. But if it is in grade 6, right, and the operation is done, one may need to wait for some period of time for the thing to take place before you start moving the shoulder. I think as not maybe physiotherapist, we should know again full motion and function depends upon the severity of the grade of the injury. Grade 1 takes 10 to 14 days, whereas grade 3 takes 6 to 8 weeks. 6 to 8 weeks. So one shouldn't at least rush it. Right. Dysfunction. There are many things that can happen to acromioclavicular joints. Right. I try to one of them. Right. Joint. I think I have a picture here. You can see it. This acromioclavicular osteoarthritis. So the head of the bone is inflamed. And the acromion, and you can imagine what this could produce. There'll be pain, severe pain whenever patient is moving the joint, and there'll be swelling at least of the joint. Over time, joint can wear out and get larger with spurs forming around it. These spurs are a sign of arthritis. Right. AC joint wear and tear is common in weightlifters, especially those who bench press, who do press up. It can happen there. All right. Treatment, you can apply ice, can move the joint, right? We apply ice for 20 to 30 minutes, they are able to joint, it reduces inflammation. So then we can do acromioclavicular joint mobilization. Right? Then how do you do that? You stabilize the scapula and try to use this thumb to do anterior glide of the clavicle. You move it, but don't move it when it's highly inflamed. Please, when there's degeneration there, don't move it. If there's degeneration, you can try to move there. I put the literature there for us to read. Then we have sternoclavicular joint, right? That's something this day I want us to see as we are going on. Right? The sternoclavicular joint is an articulation between the clavicle and the manubrium of the sternum. the saddle type of joint with tongue. Yes. Sternoclavicular joint is the exoskeleton. Now imagine that this joint is not there. Imagine that this joint is not there. So that shows that this shoulder will only be free. And don't forget, there is no articular surfaces at the scapulothoracic joint. If you just and take off, go posteriorly and go up. The God has used this sternoclavicular joint to bring the shoulder joint into the sternum to complete the articulation. Right? Don't forget that acromoclavicular joint, there is sternoclavicular joint. So all these ones are what bring the shoulder into the main body. That's it. These are the articulation there, the main body. Right? The sternum joint is formed by an articulation between the three surfaces, sternum and the clavicle, manubrium, and the sternum. Yes, I have another picture here for you. Then the articulation of it are covered by fibrocartilage, right, as opposed to the hyaline cartilage present in the major joint. So, right. Then in the sternoclavicular, we have what's called joint disc. As if you have menisci or meniscus in the name. So we have joint disc. And joint disc is what really pushing the clavicle and the sternum, which prevent osteoarthritis. Right? It's surprisingly incongruent, and because of this incongruency, a joint disc is present. What we are trying to say here is that I think I have a picture here. Yes. You can see this. Can you see this?
Yes, sir.
Yes,
I think
sir.
you can see,
Yes, sir.
you can see the great work of God here. This is just the articulation we have that joins the clavicle, the back, the shoulder into the sternum. Right? Here we now have the cartilage. We call it disc, articular disc. That's what we are seeing here. This is what we are seeing in the. I think you can see my console. Yes, this is what we are seeing here. So this is what allows articulation, so to say, and to be stable more, right, with the joint. So and you have your ligament, interclavicular ligament, anterior sternoclavicular ligament. So God now surrounded with every ligament so that this will not shift. That if there's a fracture of this sternum, the rib will come out, and all the whole shoulder complex will be scattered. So we thank God for the good work of God. So that's what we have there with the disc of the sternum. Clavicular ligament extends to the border of the articular surfaces. Articular function. It's lined internally by synovial membrane, which produce synovial fluid to reduce friction between the articulating structures. Ligament. The ligament of the sternum joint provides more stability. There are four main ligaments that I've mentioned them. Sternoclavicular ligament, internal clavicular ligament, pathophysiological ligament. All those ones were what keep the clavicular ligament down, right? They stabilize it. Movement. We have only a few movements there. We have elevation, we have depression, we have protraction, we have retraction. All those ones were movement at the shoulder joint. So when those joint move, shoulder joint move, they tend to move the sternoclavicular joint. Do you understand? Take it off, take it down, take it off, take it down, take it off, take it down, take it off, take it down. Retraction, rotation of the shoulder joint. So that's the joint that you have there. Mobility and stability. For the mobility, being the type of joint it is, being a saddle joint, it can move in two axes. Can move in two axes, just up and down. Then articular disc. This allows the clavicle and manubrium to slide over each other more freely. But by virtue of the disc I show you the other time, it allows the joint to move freely, right? Allowing rotation and movement are not prolonged. They were not prolonged. You understand? And that's what you feel when you are mobilizing that place. Possibly there's a stiffness of the shoulder joint, maybe classical, then you can visualize it. And considering now where you are now, if you hold your scapula, just hold your scapula and try to move your shoulder up, you will discover that that place is moving. That place is moving. So that's the movement we are talking here. Do your retraction, do your lifting up, do the flexion of the elbow, no, shoulder, I mean, do the extension of the shoulder. You discover that there's a movement there. There's a movement there. You have the posterior movement and anterior movement, not flexion and extension as usually observed in the normal joint. The stability, you have joint capsule, you have the ligament and the innervation. Sternoclavicular joint is supplied by medial supraclavicular nerve, the C3 and C4, and the nerve to subclavius, C5 and C6. All right. Yes, there can be dislocation of the sternoclavicular joint. There can be dislocation. Right. The dislocation of sternoclavicular joint is rare and requires significant to remove it. You can see the way God has planted it. Because you know, it will be just somebody is landing on his foot on the down clavicular joint. All right. There are two main which may result from blow to rotate the shoulder backward. Then there can be posterior. Then this is less common. Result from the force driving the shoulder forward or from direct impact to the joint. In adolescence, the artificial growth plate of the sternal end and on the clavicle has not fully formed. Therefore, it can be easily fractured and make the place to be dislocated at least superiorly. Right. Yes, I think we are getting gradually to the end of the show. This is scapulothoracic joint. Right. Very, very interesting joint. In some of the joint, all the joint that we are studying. But in this way, there is no real articulation. It is just a flat bone that God has used and put it on maybe a line or line of some small bone or straight bones that we call ribs. And that's what you are seeing here. That's why we call it false joint. Right? Scapulothoracic joint is not a true anatomical joint. Yes, but it's rather considered as a unit that gathers the sternum, sternoclavicular, anatomical joint, and the junction between the anterior surface of number one scapula and the thoracic cage. Yes, that is what you have there. That's what you have there. The scapula, the clavicle, right? The scapula is now resting on the ribs. We call it thoracic cage. The lateral component is used to divide the scapulothoracic joint the narrowest way to speak. Yes. The function of this joint is to enable and integrate the movement of the scapula against the underlying chest, chest wall with the movement of the upper limb. So this one allows the glenohumeral joint to have its function properly. Because when you move the joint up, either abduction or flexion, the scapula there will support it. It's going to go inferior when you move it up, right? And when you move it down, it's going to go up, superior when you move down. So they serve as supporting bone. That in manual therapy, we say we have component movement. Component movement. Component movement in the sense that they assist some movement. They are additional movement that you have when a major joint is moving. You don't use shoulder to hold, you don't use shoulder to throw something, but assist this, what do you call it? The shoulder, no, you don't use the scapula, I mean. But assist the shoulder because you can't do anything of your shoulder if the scapula is not functioning. Right? That's what I'm trying to say. Function of these joints will enable to integrate the movement which I've mentioned to you before. Right? Yeah. I put here the anatomy, which I think some of us may be interested in. Right? Of the true joint, right, doesn't have specific articulation, ligaments not in the joint capsule. There's no ligament, there's no joint capsule. God is good. Though. The classical approach to describing the anatomy of this joint is to analyze each of the three components: the scapulothoracic junction, right? That is where the scapular flat surface of scapula is resting on the ribs, right? Anterior surface of the scapula and superior lateral surface of the rib cage of the thoracic cage. The scapula is resting on it. The former slightly concave. Yes, that means the anterior side of the scapula is concave, while the later, the rib is convex, forming concave and convex surfaces, possibly that of the hip. But are they true? There is a line joint, a false joint. Instead, they are separated by the subscapularis muscles that fill the subscapular fossa on the anterior surface of scapula. The serratus anterior muscle, which attaches to the thoracic wall, and the fascial space between the two muscles. So those are the ligaments that hold the joint together. This fascia, yes, is filled with loose tissues that facilitate the gliding movement of the scapula. Yes, I try to put this picture here as well to see the supraspinatus, right? The coracoid bone and some of the structures inside, right, that makes the joint to be a bit useful, at least for us. Yeah, by virtue of, right, there's need for scapular stability, and that's why trapezius is useful, anterior is useful, then we have medial stabilizer of the scapula. So those group of muscles, they enable the joint to be stable, to remain where it's supposed to. If not, it will have fallen down. These muscles are also the main muscles of the scapulothoracic motion, while the muscles, where is it now? Sorry, while the muscles of the chest wall and the back assist them, at least in the movement. All right. So the innervation, as a scapula, so these are some of the muscles joined as innervative movement. All right. We have the scapular mobility, which is important for proper positioning of the shoulder joint in space. Scapula moves by gliding against the chest wall in three angles of freedom, right? We have the elevation, we have protraction, we have internal rotation. All those ones, they have their degree of movement. We have depression as well, that all of us can do that whenever we move. And when we do each of those movements, your shoulder too is moving. Your shoulder is moving, can feel the scapula moving. So cannot just do them in isolation. Do them and other joints of the body are moving as well. That attached to it and by the ligament of acromioclavicular joint. So you can see how important acromioclavicular joint ligaments are. The protraction and retraction of the shoulder joint happens around a vertical axis passing through the lateral end of the fibrous. They are limited by conoid and trapezoid ligaments that I've shown you before, right, of the acromioclavicular ligament respectively. If not, the shoulder will have, no, the scapula will have taken its time and disappeared to the blue moon. Yes, great, good, 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 good. I love this. I love it. I think you are with me.
Yes, sir.
Yeah, we have depression. We have depression. Which are the muscles assisting that? We have small dorsal. We have lower trapezius. I think I put trapezius muscles here. No, that we have and trapezius. We have retraction, and we know what retraction is when shoulder is trying to move back. When we have upper trapezius, we have middle trapezius, we have lower trapezius, we have rhomboid muscles, we have lacrosse dorsal. So for the retraction, so those are the muscles. And look at it, we have elevation and depression. So that's the picture that shows that we have protraction and retraction. It's as if the shoulder, no, the scapula opens up and closes, opens up, open, close, up and down, especially at the inferior edge. So you can see that the inferior edge will move, right, laterally and come back. So that's why we have the rotation of the shoulder again. And most responsible for that is lower trapezius and serratus anterior. Right. I've mentioned all the muscles that are responsible for the movement. I don't have to possibly refer to that again. Right. I think we can move on. Concurrent contraction of the levator scapulae muscle neutralizes rotation, thus producing the elevation of the scapula. So that's the joint that moving there. The present rotation are primarily passive movement, yes, happening with the relaxation of the trapezius and levator scapulae, and consequently drop of the scapula by the force of gravity. First fiber of serratus anterior muscle can activate the shoulder, while the levator scapulae, rhomboid, and pectoral major are active internal rotators. All right. So I think we are moving on. Yes. We want to discuss about some of the dysfunction of the scapula, especially scapulothoracic disorder. We want to discuss it, and I think after the class may end. We have what called scapulothoracic dyskinesia. This dyskinesia, right, are in three categories. We are going to see it as we are moving on. It will involve with and when scapula variation. Who's talking now? Please kindly mute yourself. Sorry.
Yes, go on, Prof. Yes, go on.
That now? Okay, I'm coming. Just 1 minute. Yes, 1 minute, please. How's it now? Okay. Sorry, this has disturbed me. Okay, no. Just 1 minute, please. I couldn't see the thing again. Let's appear to the blue. Sorry. Okay. Right. Okay. Okay. Sorry, I couldn't. This is just disturbed me here. Okay, let me change to my what do you call it, to my iPad. The laptop is misbehaving. Just 1 minute, please. I will just yes. Just 1 minute.
Okay, so let me use this opportunity to chip in some message. The slide will be shared on our YouTube portal.
Okay,
there will be a Google link within the video description. So when you go to our YouTube portal, you can just tap and download the PDF documents that Prof is using for the presentation today. Subsequently, all the documents for the presentations too will be shared on the portal as well. Therefore, we encourage all to get to our portal, subscribe to our channel, and send all your recommendations and the comments that you have for us to improve our videos. Thank you very much. Prof, if you are ready, you can proceed.
Am I online?
Yes, sir. You can hear, sir.
Thank you. So we are talking about dyskinesia. Sorry for the break in transmission. The laptop that's trying to misbehave. This may occur from overexport injury. So what happened here is that the scapula, right? There's a displacement somehow of the scapula. Maybe there's an impairment and the nerve is not too intact. In its most severe form, scapulopelvic dyskinesia is the result of a nerve dysfunction, either traumatic or idiopathic causes, right? So loss of scapular control is often missed, so patient is unable to control the scapula. The patient may develop pain in this overall shoulder motion. So at times it may be mild, at times it may be serious. In some cases, the patient may have shoulder instability due to failure of scapula to fully rotate. Some patients present with pain that may seem like a rotator cuff problem. This is due to abnormal motion, which allows rotator cuff to hit against a common process. Right? The condition has been called, right? Has been called shoulder instability or shoulder dyskinesia. There are some causes. You can have shoulder-related cause, you can have neck-related cause, you can have posture-related cause. So those are the three areas that can really cause spinal shoulder dyskinesia. Shoulder-related cause, right? In this case, it's associated with acromioclavicular instability. There can be shoulder impingement. There can be rotator cuff injury. There can be glenoid labrum injuries. That is fracture of the clavicle. There can be inflexibility of the pectoralis minor or short end of the biceps, right? And stiffness of the posterior venoid cavity can be counted for this group. The next related one can be mechanical neck pain syndrome or cervical nerve root syndrome. Then there can be the posture-related one that can be excessive kyphosis or cervical lordosis. So all those ones are what will really cause dyskinesia of the shoulder joint. That again, you can see this one now. This is showing additional pain regarding the shoulder kinesia. In this case now, we have inferior angle prominence. That is A. You can see the inferior angle that's very, very prominent here. The mid one, you can see the medial border very prominent. The top one, you can see the LA and scapular elevation. The scapula is elevated, right? You can see that in other ones, the scapula is not well elevated, but in the third one, it's very elevated. So these are the three categories of shoulder dyskinesia that we have. So they may be called mean scapula as well, because we know them to be more or less mean scapula, especially the stage 2. All right. We are getting towards the end of it. Then scapular winging. When one or more of the scapular stabilization muscle does not work properly, right? Maybe subscapularis or supraspinatus or teres major, they are not really working very well. There can be what we call it wing scapula. In the case of wing scapula, titular thoracic nerve palsy, serrator anterior palsy, most cases recover, but do so slowly. And this may take up to 1 or 2 years for maximum recovery. Physiotherapy is not generally helpful because when there is injury to the nerve, you are careful because if you mobilize the shoulder, I tell you the truth, you can tear the muscle, or the muscle can go into more and more maybe severe, and the shoulder, the joint may be dislocated. So that's why you have to be careful. Right? You can only do active exercises to when possible to strengthen the muscle if it is too strong. When we calculate this to anterior, serrator anterior palsy persists and the patient is disabled and or aspirin, surgery may be indicated. All right. Then we call this one trapezius palsy. You can see the normal scapula. You can see the one where you have the palsy here. In this case now, the trapezius muscle, right, is weak. I try to put here trapezius muscle. If the trapezius muscle is weak, the whole scapular area, right from the stand of scapula, we come down, we depress. It will depress. And that's what we are seeing here. And that's what we are seeing here. Consider there's asymmetry on the left and the right shoulder joint. So in that way, the muscle here, they are very weak. the nerve supplying them is possibly not intact, and the weight of the scapula has not descended. We call it trapezius palsy. A less common form of weak scapula that may also result in weakness and pain. Trapezius is a very large triangular muscle. That's what we are seeing here, right? Which support the scapula, suspending it from the spine. So this one is taking the spine, the scapula towards the shoulder, and take it into the space, right? It also helps an individual to shrug the shoulder. So when you take up your shoulder, right, is the work of trapezius. When it is not functioning properly, the shoulder appears to drop, to droop. That's what we are seeing. And the scapula cannot rotate outward. So the venous socket downward, and the patient is unable to raise up his arm. So the patient will not be able to do abduction fully. No, it's not going to be possible because of the problem that patient is having here. Then there can be combined loss of function. So the third type of weak scapula occur when there's combined loss of function of the cervical anterior and trapezius muscle. This usually associated with a conditioner called facioscapulohumeral muscular dystrophy, FSH, not follicle stimulating hormonal, but facioscapulohumeral muscle dystrophy. Patient may present weakness so severe they are unable to raise the arm either forward or backward. I'll give an example. See the picture there, Alice. So this is the picture that you are trying to see here. The patient is able to lift the arm up because of the combination of that muscle that are affected. In such a case, when the tendon transfer has failed, there may be no tendon transfer solution. For this patient, a fissure of the scapula to the rib may be needed. Right? And this may give stability to the scapula, which allows the patient to raise up his hand. Right? Yeah. Conclusion. Right. I think shoulder complex is very complex. It needs a lot of attention. One cannot move one aspect of the joint and leave the other. Again, whenever you are doing your assessment, make sure that you do the holistic assessment and make sure you give holistic management to the joint. If you concentrate on one aspect of the joint, the other will be suffering. One may not be able to get good results. Thank you very much. My friend from Ghana, I appreciate you. Thank you. God bless everyone.
Thank you very much, Prof, for this insightful message. And I think it's time for questions. In case your environment is very noisy and you want to drop the question in the chat box, you can drop the question. But if your environment is great enough to speak, you can go ahead and ask your question. So you have 5 minutes for this section. And then
Thank you, sir. Thank you, Professor Joe. My name is Olakunle Afolabi. I'm speaking from Nigeria. Please, sir, in the case of scapular winging, how can the sufferer be helped? Because I heard you mentioning that you must not do anything to the shoulder at that time so that you don't injure the long thoracic nerve. So how can the patient be helped so that he can recover fully, knowing fully well that people in this part of the world, they fear surgery? So that's my question, sir.
Yeah, thank you. I think you can hear me.
Yes, sir.
Yes, depending on the causes of the wing scapula, I've put a lot of many causes here. Right? After the assessment, you will try to come to understand what the cause is. So you may not leave the patient out, but there are some things you will not do by virtue of what you have learned from this lecture now. You know, most of the time when somebody is having pain, especially at the scapula, we try to do mobilization of the scapula. You cannot mobilize somebody that is having trapezius palsy. That's where I'm going. However, You can still do your strengthening exercises. Do you understand? Right? You can do your strapping. So those are something that you can do. Right? Because most of the patients, they don't want to go for surgery. Do you understand? So when you study very well, they have to know what to do. Then, when you discover again that it is the trapezius that's affected, right? You can decide an exercise to strengthen the trapezius. Stimulation is one of them, which I think all of us are familiar with. Do you understand? So when you do that, you are trying to strengthen the trapezius, and that will push possibly the scapula up to a certain extent. So what we are only saying that you may not give mobilization exercises to such scapula when you know that the trapezius palsy. So that you are not going to do more worse or more harm to the patient than helping the patient. I think I addressed your question.
Yes, sir. Thank you, sir.
God bless you.
Right. If there is any other question, we can go ahead and ask. We still have some few more minutes to ask our question. Okay, so Prof, there is a question in the comment section. It says, what are the biomechanical and chemical and clinical implications of these variations?
Are you talking of palsy or which one? There are a lot of variations that we have mentioned here. Which specific joint is he talking about?
I think he's speaking in relation to the quadrilateral space.
Which space is that? Is it of the pathophysiological joint or glenohumeral joint?
Okay. Dr. Afolabi, if you can hear me, can you give clarification to the question, please?
Thank you very much, sir. I want to appreciate Dr. Michael for this opportunity and Prof for the in-depth analysis of the shoulder joint. And there is a quadrilateral space, the muscle crossing each other. I don't know if Prof can shed more light on it. Quadrilateral space and the clinical implication.
If you are talking about muscle crossing each other, right, we have to be specific of a joint we are talking about. Are we talking of the joint at the back, scapulothoracic joint? Are we talking about the glenohumeral joint? Are we talking of the acromioclavicular joint? Are we talking of sternoclavicular joint? Very important. The only area that you can say muscles are crossing majorly are possibly at the glenohumeral joint. And when you look at the muscle there, you are talking of long head of biceps, you are talking of deltoid muscle. And when you look at those muscles, all of them, they have their specific role that they play. The action of one muscle does not disturb another one. What they do is that they try to synergize. Right? When one starts, the other one takes over from that. So then the effect that maybe one contraction is affecting the other, I'm not too sure we have such specifically in the shoulder joint. But if the man that is answering the question, if he has some information around that area, then you may be ready to listen to him. Maybe there's an observation, maybe there's an information on such kind of muscles that are crossed in the shoulder joint, that possibly their effect is interwoven. Then we may try to listen to that, but in the webinar. Thank you.
Okay, thank you very much, Prof. Dr. Afolabi, do you have a follow-up? Okay, great. I don't think so. So is there any other question we have to address? We can have extra 1 minute for that, and then we close today's section. Okay, so there is a question in the comment. It says, "Good evening, Prof. My question goes thus: I'm aware there could be some anatomical variations in the shoulder complex. What are the likely biomechanical and clinical implications of these variations?" Prof, could you get to the question and help us address it?
Yes, thank you. There can be variations as well, as you mentioned, right? The major biomechanical that may happen is possibly in terms of movement and in terms of possibly some of the pathology that really happen to the joint. That when we talk about let's start from the glenohumeral joint, that you see the articulation there. It may be easier for somebody to have anterior dislocation when there are mechanical variation or anatomical variation in its joint. Okay, maybe the head of humerus is more lateral, right, and the capsule of the joint is a bit weaker, more weaker than the others. Right, just a slight movement of the head. Right, when somebody is doing extension and internal rotation, normally that somebody will do, will lead the joint into anterior dislocation. And that's why some, they have anterior dislocation more recurrently than any other. Right? Some may have posterior dislocation by virtue of that variation. Some may have possibly inferior dislocation by virtue of that variation. Again, the acromiocapsular ligament as well, right? If the arch there that I show you by virtue of those ligaments, if they are not as strong as they are, or it is not as it's a bit far from each other, and those ligaments are slack, then there can be a problem. So we are talking of this. I think I make mention of there's another structure that we have here, right? Talk about so major variation we have could be possibly at the shoulder joint. Number one, that's the humeral joint. It can be at the acromioclavicular joint. Number two, and in that way, it can easily make such individual to have more dysfunctions than people that do not have such variations. Then the movement that they have, normal movement may be abnormal. So that's another factor that one can consider. Abnormal in the sense that I was in the class one of those days and I was talking about shoulder joint. And one day, I think the name was either Goodness or what. So the girl was able to fold her hand at the back, not right, unlocking the hand. The guy took the hand to the front. I was amazed. And he folded her hand again at the front and he took it to the back. Do you understand? I couldn't imagine it. No, none of the members of the class should be able to do it, was able to do it. They were looking at her like somebody, like a magic. And she does it conveniently, not having anything. So those are kind of variations that we may have, right? The movement may be affected, somebody may have dysfunction, right? Then when we have some anatomical variations, I think that's what we have. And the variation can be in any of the joints that we have talked about. So that's going to really affect the biomechanics and possibly the movement available in that joint. Thank you for the questions. Maybe by next time, can put some variations in the anatomical teaching of something like this. Thank you.
Well, thank you very much, Prof. I think our time is up and we want to adhere to the time. So our next two sections, we are going to conduct another model. And for that, we are going to basically talk about the physical examination and the diagnosis of the shoulder conditions, the various conditions that we have. Over there, we're going to delve much into the assessment and the current evidence base approach in addressing some of these clinical conditions within our field. And our last section, we will basically go into the management protocols, where Prof will enlighten us concerning the various manipulative techniques that could be adopted in our treatment protocols. My dear PTs and professors and doctors in our midst, thank you very much for coming. We appreciate your time, and we encourage you all to subscribe to our YouTube channel, Physio Instructors. We will be posting the slide there, and you can download it for future reference. We appreciate your time, and my last appreciation goes to Professor Ojuo. I think it's been a great pleasure seeing you in Nigeria, and definitely we'll meet again this year in July. I'm very glad to once again see you there. Your last comment, Prof.
Yes. Again, I like to appreciate my friend. It is good to meet people, especially people of value. And I want to appreciate you again, and I want to encourage as many of us that have not been attending workshops and conferences to kindly have a change this year, change of attitude to such. Right? My came to one of our conferences last year at Kaduna from Ghana, and that's what brought this webinar to us here. Right? And this has even ignited some other decisions, right? Even from the from Naum, that we may have to discuss maybe when we get to the conference again. I can be having this maybe continuously, right? I know at Captain, we are trying to see what we can do to give our webinar every month, right? We are still going to have a time to resuscitate that. But if we have not met in Kaduna last year, this will not come to play this year. And as he has promised, he's going to come again to our workshop at Bugagwalada, Abuja this year, where we are going to be discussing on neck, cervical region, the examination, the management, the exercises, evidence-based, and what have you. So I want to appreciate you, please, and I want to pray that God is going to keep you up, going to be strengthening you and energize you more and more. All right. Your meeting you on that day has been a blessing, not only to me, to the Naum, and to physiotherapists in Nigeria as a whole. Thank you very much.
All right, thank you. Our mission is very simple. We have to project African PTs to the world. We have a lot of things in us, and we should let the world see. Thank you very much for coming once again, and have a blessed evening. Bye-bye.
Thank you. God bless you. Yeah, good. See you. Can I put on my video now?
Thank you, Prof, for this. Thank you, Prof, for the presentation.
Thank you.